As you're coming in, if you can just make sure that you're on mute, that would be helpful. Whenever you're ready.
Okay, I was waiting for my cue. Good evening. I'm Alan Womax, and I have the pleasure of chairing the Leadership Council of the Suicide Prevention Alliance of Northern Virginia. Thank you for joining us tonight as we recognize Mental Health Awareness Month. Our webinar tonight, From Signs to Support, What to Do When Someone You Love is Struggling, is an exciting and very important event. It will also be a little different from the webinars that many of us attend because it's going to be a fireside chat featuring our speakers from NAMI, Northern Virginia, and the American Foundation for Suicide Prevention. Our speakers tonight are Rebecca Kiesling and Ali Walker. Rebecca is Executive Director of NAMI Northern Virginia since 2022 and is a member of the National NAMI Board of Directors. She's passionate about creating communities that are stigma-free, advocating for real change, um, and breaking down barriers to resources that can improve the lives of those affected by mental health concerns. Rebecca was awarded the 2024 Live Healthy Alexandria Fairfax Award for Behavioral Health. NAMI Northern Virginia was recognized as the 2025 NAMI Outstanding Affiliate of the Year. She has degrees from George Washington University and Georgetown University, as well as a certificate in leadership and management from Harvard Business School. Ali Walker is a practicing physician assistant in Washington, D.C. in adult critical care medicine, a leader in clinical quality, and an adjunct instructor at the George Washington University School of Medicine and Health Sciences, where she completed her master's and doctorate in health sciences. Ali is immediate past chair of the National Capital Area chapter of the American Foundation for Suicide Prevention and serves as the foundation's national chapter leadership, but serves on its council. Ali has presented on suicide to audiences including NASA, the Navy, professional athletes, clinicians, and others. Both Rebecca and Ali serve on the Suicide Prevention of Northern Virginia's Leadership Council. And I'm going to turn it over to Rebecca and Ali, and thank you for doing this tonight. I appreciate you both, and thank you for joining us.
Awesome.
Thank you. Hi, Allie.
Hello.
How are you?
I'm so excited to be doing this tonight.
I am too. This is the first time Allie and I have gotten the chance to do an event together. So, which is odd because we see each other all the time in different meetings. So I'm excited that we get to do this. We wanted to create it very informal. We wanted this just to be us talking. Because I'm sure everyone here has been through about 1 billion different presentations. And it's what we do. It's part of our part of our DNA at this point, I think. And so we thought if we were to be a little bit more informal, we could dig in a little bit more. Our wonderful Caitlin is also on, and she's going to be manning the chat for us. So if there's questions as we go through kind of some discussion points, if you have questions, specific questions, please let us know in the chat and we'll try to get to them all. Sound good? Allie? Okay.
Sounds good to me.
So I'm going to start because I was talking. How do we know? So the topic here is helping people what to do when someone you love is struggling. But how do you know if somebody is struggling?
I think this is, I feel like this is a complicated answer, right? Because we have we have some warning signs and things that we're going to get into that we need to look out for. Um, but we also have this like gut sensation, right? That's like kind of stress meter in our minds that helps us kind of pick up on when somebody that we know seems a little bit off in some way. And I think that what's been really interesting, so I've been volunteering in suicide prevention for the last 16 years now. And Rebecca, I don't know about you, but I feel like in that time I've had the opportunity to see kind of how our culture has shifted and how stigma has changed over that time with mental health. And so I think that we have gotten into a much better place in terms of having an awareness that some of the behaviors that we notice in our friends and our family members are not just them being grumpy or cranky or lazy or sleeping a lot or whatever it may be, but it may actually be a symptom of something. So I think, and I'll talk about some specific examples, but I think the thing I wanted to kind of start out with is just emphasizing the importance of listening to your gut. Because usually we have a feeling that the person that we're around just seems a little bit different. And I think that my hope in our conversation tonight is to empower people to have some recognition of that sensation that they're getting, that red flag that's kind of going off in their mind, and to be a little bit more inquisitive and curious about that.
Yeah,
So, oh
I
yeah, go
think
ahead.
that, yeah, I think you're right in terms of it's not just a bad day or a string of bad days. Because I think even with our younger people, we're paying more attention to, oh, she's a hormonal teenager versus maybe something is, maybe it's something I need to look at a little bit more. But I hope as we're talking, and like you said, gonna go through some of those warning signs. I think that one of the things I want to talk about and get off, we talk about trigger warnings and things like that. We might talk about some stories that might be difficult. Never feel bad about having to, walk away from your computer and take some deep breaths because it's not just about helping people you love, it's about taking care of yourself as well. Um, I think we are, at NAMI, we're really strongly part of, breaking stigma associated with mental illness and mental health concerns. And so you see these younger people talking about it. They're talking about their feelings more, and we still have a lot more to do, a lot more work to go, especially in some, underserved communities. But we're getting there.
Mhm. Yeah, I think, as you were talking, I was thinking about anger, because one of the things that I think, so Alan mentioned in my intro that I'm a physician assistant, that I work in critical care medicine. And so I, a lot of times, kind of relate back and forth between what I do in our mental health work and what I do clinically, because there's so much overlap, right? All of that is part of healthcare. But in my clinical work, I experience a lot of anger. Sometimes that's from colleagues, sometimes that's from patients, sometimes that's from patients' family members. And I remember when I was in my training and somebody told me anger is one of the most nonspecific symptoms of mental distress. And
Hmm.
I thought that was such an important takeaway.
Yeah.
And I want to say that was I did a psychiatry rotation in pediatrics, which was really fascinating.
Oh,
And in in youth in particular, like we kind of have that stereotype, right? Like the angry teen, but it's not isolated to that age range, right? Like we experience anger with others all the time, and I wanted to flag this because we talk about the different kinds of things that kind of set off our internal alarm system that somebody's not okay. And I think anger is one that's really important to pay attention to in particular, because it is so nonspecific, meaning that like, what is it that makes us angry, and what lives underneath that anger? For me, a lot of times it's fear, right? My patients might be fearful, their family members might be fearful. Sometimes it's disappointment. You know, I was really hoping that somebody would show up and support me, or think of me on an important day, and I feel disappointed, and that hurt then translates into frustration and anger. And I think when we talk about suicide prevention, we have to think in that same light. We have to be really curious when we hear that somebody's angry or that we're experiencing that, and feel a little bit more inclined to lean into that.
I think anger is super interesting to talk about. Having discussions with some of my friends who, um, and colleagues who are in the Black and African ancestry community, the labeling of that's just an angry Black man, or, instead of actually looking at the symptoms and trying to figure out why they're angry. It's just a label. And I think we need to be really careful with that, because this has been historic when children, when especially Black boys and teens are labeled as angry, because what we're doing is we're not looking into what is causing the anger. We're ignoring it. And it's a big reason why our young Black men are going underdiagnosed, because it's a label, and it's one that's still there, very much so. I know some of my, female counterparts as well have said it doesn't go away, and it's not just for our young Black men. Um, because they're stereotypes and stigmas that are just so prevalent. So anger is very interesting that's a very interesting topic, I think.
Yeah. I'm curious, when you think about warning signs, Rebecca, what are some of the things that you tend to look out for in somebody? You know, when that alarm
Yeah.
system is starting to grow, what's kind of pointing you in the direction of thinking, ooh, like we're really getting into hot water here?
I think we have to understand that trying to tell the difference between expected behaviors and what might be signs of something else isn't easy. I gave this speech once, um, it was in a assisted living facility. There were about 2,000 people, but we had about 200 in the audience, aging adults. And I asked the question, how many of you have been to a doctor and been told that's just part of getting old? Because it happened to me when I was 40. 40. Um, my neurologist, I was saying I was having some memory loss, some memory issues, and I thought it might be some medication I'm on. I get migraines, neurologist. Um, and he's about my age and says, no, just part of getting old. So I can just imagine every single hand in that audience of about 200 people went up, because that's an expected thing.
Mhm.
But when we look at suicide, what age group has the largest suicide rate? It's our older adults, it's our aging adults.
Mhm.
So there's no easy test that you can to see if someone has a mental illness, or if there's typical behaviors, or maybe it's a result of a physical illness. But we look at extended time. So in the industry, it's 2 weeks. Now, that's not saying that at 11 days you can't, or 16 days you missed it. But we say around 2 weeks that a behavior has changed. When we go back to young people, I have three daughters ranging from 16 to 23. Their moods change every day, every minute sometimes. But again, that 2 weeks, we look at excessive fear or worries. Maybe feeling sad or low. Again, remember this is an extended period of time. Confused or problems concentrating. We talked about anger. Avoiding friends or social activities, even if you have an employee that's calling into work more frequently or leaving work early. Sleeping habits, eating habits, because we know physical health and mental health are so intertwined. Um, Perceiving reality is a big one. So Are we starting to have delusions, maybe hallucinations, where there's things that they're experiencing, they think, but they're just not based in any kind of reality? You have to look at overuse of drugs and alcohol. That can be a big sign because we always talk about with substance use disorder, what came first, because about 80% of people with SUD also have a serious mental illness. So what comes first? And a lot of people will say, we work a lot in the jails, and I'm going to be this is generalizing a lot, but typically men will say that their mental illness um, caused their um, caused their abuse, their substance use issues, where women will say their substance use issues were problematic to their mental illness. So it's interesting. We another When I was growing up, one thing you never did ever was talk about suicide. But we can ask that question now. We know that asking the question, if somebody says they're thinking about suicide, you have to take that seriously. You have to, and there's nothing wrong with asking. You're not putting a thought into their heads. Instead, you might be that one person that noticed they're struggling. So there's so many more than that, but I want to make sure that we understand we're not talking about a day, because I don't know about you all, that could be, Tuesday, but it's when it is, if my family knows, I do suffer from depression. My family knows what to look for now, and it's not a bad day. It's bad days and what that looks like for me. But when you're talking about kids in particular, changes in school performance, maybe not wanting suddenly to go to bed or to go to school, maybe more hyperactive, nightmares, suddenly acting out in school when um, in my family, we have one of my kids has severe anxiety, generalized anxiety disorder, and her school never saw it. Her school never saw what we did because here is her safe place.
Mm-hmm.
And it wasn't until a teacher noticed that we actually were able to get that diagnosis. Temper tantrums, things like that. We can still have these things in young children. It just might be, at a different scale.
I thank you for that. I mean, that was such a good description of the many different kinds of things that we can look out for. And I love your point about the fact that we're looking at things that are not just in the short term, right? That, I mean, I guess, it's all relative. 2 weeks is not a really incredibly long amount of time, but it's about that consistency, that change that kind of manifests and persists, right? And the other thing that I kind of heard you saying were words like suddenly and new. And so when we do presentations with the American Foundation for Suicide Prevention, we talk about these warning signs in these three big categories, which you really covered, right? Which is talk. What are people saying? What are the words that they're using? Behavior. How are they acting? And then their mood. What mood are they exhibiting? What are they seeming sad? Are they seeming angry? Are they seeming really anxious, nervous, worried about something? And there's so many different things that can fall under these buckets. But one thing that we really emphasize that kind of goes along with all of those words you're using is that it is representing a change from what's normal about the person that you know. And I think that goes back to where we kind of started this conversation out, which was like, how do you know when somebody is having a hard time and when they may be struggling? And I think the reason that we get that alarm signal going off in our gut is because we notice there's a change. Right. And sometimes it can be really obvious, and other times it might be a lot more subtle. Like your friend that usually accepts your dinner invitation every month, and now they are saying they're going to come, and then they're not showing up at the last minute, or they're not answering your texts as often, or picking up the phone when you call them. Or maybe, you mentioned substance use, which I think is hugely important. Maybe they're now being a little bit more reckless in their decision making. They're trying more drugs. They're drinking more heavily. Maybe they're racking up speeding tickets, kind of living life on the edge. And so those behaviors or the moods that you might witness, suddenly they've got mood swings and they're angry all the time, or they seem really sad, or really, like I said, really nervous, anxious, worried. All of those things are changes. And so I think it's really helpful to recognize that rather than having to memorize a really specific list of things, right? Because mental illness can present itself in so many ways, kind of taking that zoomed out view and thinking about this as this person is different in some way than they were before. And in medicine, as a clinician, sometimes this can be hard to pick up on because we may not have the same like continuity of being around the person all the time. And that's where it's so important as friends and family to be able to pick up on those things, because you probably have more exposure and opportunity to recognize. But even in the medical side of things, I mean, if a patient comes in and they are kind of disheveled and maybe they look like they haven't taken a shower, or they're missing a lot of appointments, these are all things that kind of stand out to us. And so just like we're talking with everybody here tonight, and on whatever people come back and hopefully watch this to kind of learn more for themselves about how they can make that recognition, we're also looking at that and training health care workers as well to kind of be another partner in this process of being able to recognize when something is going wrong.
I think that recognition, you talk about in healthcare workers, and I know both AFSP and NAMI do work in that space. It's not just our behavioral health clinicians that need this. It's almost showing that empathy is a big deal. That
Mm-hmm.
You might see these things, and we teach kids to be empathetic by saying things like walk in their shoes for a minute. You're not that person. Try to understand a bit what's going on with them. And that empathy is so important. It's important for our clinicians. It's important. We do a lot with workplace mental health, and for managers, for people who are in relation with another person, of any sort, because understand that what we're looking at is a caregiver. We talk about family members and peers, those big NAMI words. A caregiver in the US that's supporting somebody with a mental illness adds about 32 hours of work to their life. So you think about that. You go to your job, however many hours, 40 plus hours a week. You come home, maybe you have kids. And maybe it's a spouse that's dealing with a mental illness. So how do all those numbers add up? But that could be the person that is sitting at the desk next to you. It could be, in your case, Allie, the person behind the curtain.
Mm-hmm.
And so it's making sure that we understand what it could look like. But as we started, going with your gut. So I guess that's a good segue to ask you, Allie, if you are concerned, if you've seen something that has that puts up the red flag in you, how do you talk to somebody about what you're seeing, your concerns about their mental health? What would you do?
So I want to go back to the word that you used a moment ago, which was empathy. And the role of empathy is so important, right? Because it's us, like you said, walking in the shoes of someone else, and we can't always do that exactly, right? I think it's important to recognize that we can't assume that we completely understand another person's experience, right? Everybody has their own perspective and their own experience, but we can do our part to try to relate to it and try to understand it and be curious and seek understanding. And I think in that way we can really demonstrate empathy. And I think that's how I would bring bring myself to a conversation with somebody that I think is struggling. And, when we were talking, I was just thinking about an experience I had last week. So, in healthcare, we have something called Schwartz rounds, and Schwartz rounds come from a gentleman who had lung cancer in his 40s, and he, in the treatment process, recognized how much of an emotional toll his healthcare journey was also having on the caregivers, and in particular, the health professionals that were treating him. And so out of this came this amazing work where health professionals come together in a confidential environment and they are able to reflect on their experiences in their work and talk about the emotional impacts of their job. And so last week, I had the opportunity to actually share my own story and reflection about patients that were particularly memorable to me. And afterwards, you kind of have a nice dialogue with the people in the room. And somebody made a comment about the mental health toll that it had taken on her, some of these experiences. And she ended up being diagnosed with depression. But something that she said that was so important was, I didn't realize that I was depressed. I just thought I wasn't feeling well. And when we are approaching somebody we're worried about, I think it's important to also keep in mind that they may not have that insight yet. And I can speak from my own personal experience that, in the past with my own depression, I did not realize that I was doing as badly as I was. And I think it's because as humans, we're so resilient and we just persevere through so many things and we push ourselves even when we're really struggling. And I think that masks the suffering that we're experiencing. And so when we see somebody else exhibiting those symptoms and we're concerned, I think that that's an opportunity to share observations and help them see through the eyes of another person just how much we're concerned. And so I think that kind of comes back to that empathy, right? So I like to, in my own personal life, in my work with patients, regardless, when I come to somebody that I'm worried about, I kind of start with that. I start by, I want to have a private conversation. This is something that, you don't want to be having this in a loud, busy public area or around other people that they might be uncomfortable sharing with you. But I like to start with that observation and say, I just want you to know that I care very much about you. And I've noticed lately that we seem out of touch a little bit, and I'm worried about you. And I was wondering if you could tell me how you've been feeling. And at some point in that conversation, I need to ask them directly if they're thinking of suicide. You said before something incredibly important, which is a lot of people have this fear that they're going to plant the idea in someone's head. And we know through extensive research that this is not the case. And in fact, not only does the research say that this is protective action, that by asking directly about suicide, we're actually helping people. But I have another personal story to share, which is a friend of mine that I volunteer with survived a suicide attempt. And he now comes and helps speak on a panel every year to training PA students in the area. And he moved out of the state, but he flies back every year to do this because he's so impassioned about his experience and wanting to share this message with other people. And he tells the story of how when he was in crisis, he was saying things and hinting at things and doing what he felt to be obvious signals to somebody in his work life. Hey, I'm really in a bad place. But he was so scared to say out loud, I'm suicidal. He wanted somebody to ask. And so, that question, to me, it just really drove home that message that not only is that question not dangerous, it's helpful, but it sometimes takes away the burden that that person is carrying of having to say it out loud themselves, right? I think in our own ways, we can all relate to that feeling that we have a thought, and that thought is something maybe we're not proud of, or maybe we're really fearful of, or we feel uncertain about. And having somebody else make the observation and ask the question gives us the freedom to explore that and opens the door to a conversation that maybe we were really afraid to have before.
I think absolutely on every piece of that. I think what's important is if you are going in to a conversation, you're starting with, I noticed that, I noticed XYZ. You have to understand that even if you don't agree with what somebody's saying, even if it hurts you because they've directed things back at you, um, it you don't, try to accept. Don't you hear them where they're at and try to accept it and don't argue and try not to be judgmental. I think those things are so important because what you're really trying to do is, even if the anger's there, or even if they don't want to talk at all, you want to create this safe environment, this safe space, um, where that person can express themselves whenever. So maybe it's not right then. Maybe they need to go back and you asked, and maybe it's 2 days, 2 weeks later, where they're like, I know you saw this. Let me tell you what I'm going through or I was going through. Um, I will say, under my own experience, when somebody says something like that to me, when I have been in my darkest places, um, I get snippy. I know I have, but when I'm ready to talk, I don't stop. I just keep going because to me, in my depression, it is a deep pit. And by having a safe space to kind of get out, I'm digging out. Actually feel like with every word, I'm climbing out of that deep pit. And that's me. Um, I think some of the most beneficial things have been for me, giving, knowing I'm getting reassurance, knowing I'm getting some information. Um, but when somebody says, I am so sorry you're going through this, that is, it's just being heard. Caitlin?
Thanks so much for you both for such wonderful insights. I just wanted to uplift a couple of comments in the chat and questions that I think leads right into what you were just discussing. Someone asked, if someone admits to being suicidal, how do we help them get out of that mental space? And then someone else asked, when someone says, I'm thinking of suicide, I'm fearful of saying the wrong thing. So what does one say, but also what does one not say? Is sometimes silence best?
Yeah, so I think maybe I'll respond to the second question first, because I think the first question about what do we do with this information is a critical question, and one that we're gonna pivot to here in a moment. But the question that you're asking about being afraid of saying the wrong thing is something that I think everybody feels at some point. And I just want you to know that you're not alone in that feeling. And I myself, I'm a suicide loss survivor. I lost a friend to suicide when I was in college. And it's very scary, right? It's scary because you love this person and you want them to be okay. And you want the actions and the words that you use to benefit that person. And you don't want to do anything that leads to harm. Um, and what I tell people is, number one, when you approach a conversation with compassion and with empathy, the words matter a lot less. And certainly there are things that, there are phrases that we can use, and ways that we can ask the question that maybe are preferable. But at the end of the day, like, I think in any human to human interaction that we have in our lives, it's how we come into that conversation that matters the most. And demonstrating to this person that you are concerned, that you're coming to them from a caring place, that you are, and Rebecca said this, right? You're not judging them. I think that's incredibly important, right? That you're giving them the space to be honest with you, and that you genuinely want to know the answer. Because I think sometimes one thing I will say that is helpful to avoid is when you make asks about how someone's doing, and specifically when you're asking about suicide, you want to be as neutral as possible. And what I mean by that is, you don't want to say, for example, hey, you're not going to kill yourself, are you? I've had that question asked to me in a medical environment, right? When they did a screener. And oh man, well, if you're asking me, you're not going to do that, are you? Well, okay, if I was, I absolutely am not comfortable sharing that with you now because I feel like you are not prepared to hear a different answer other than no. And so when you ask this question, it's really important that you use language that's non-judgmental and neutral. And so you can say, I like to say this, sometimes when people are going through a tough time and they're experiencing things like you have, they start to think about things like hurting themselves or even suicide. That can be really scary. Is that something that you have experienced? And that gives them the opportunity to say yes or no. And sometimes people might say no and they mean yes. And we have to know that we can't control other people, and they have to be ready on their side of the conversation too to accept help when it's offered. But giving them that opportunity to be honest with you is so important. And I think that's where we can avoid saying the wrong thing. We're
Yeah.
really giving them the space to be honest and listening. And that's really your role in this conversation, right? Your role is not to be the fixer. And I think we all struggle with that so much, right? Because like especially as a healthcare provider, like my job is supposed to be to fix stuff. And I have learned over more than a decade that I can't fix a lot of things. There are a lot of things that are much more complex than I have control over. But what I can do is care. What I can do is listen. I can validate a person's feelings. I might not understand them. Maybe I would feel differently than they do in a situation. Maybe I disagree a little bit about some of what they have to say. But at the end of the day, in that conversation, my role isn't to make those judgments or to try to push them to see things differently. My role really is just to listen. And that peer support, Alan, you asked a question in the chat, I think earlier about that. The role of peer support is hugely protective. We know that just having one good relationship in your life is incredibly protective against suicide risk. And so you're being there, you're being willing to open the door to this conversation. Like, even if you don't feel like it goes the way that you hoped it would, maybe you feel a little uncomfortable or you're worried they're upset with you. You need to just remember in your heart of hearts that you did the right thing. And you showed up and you showed them how much you care and you leveraged that support that you were able to offer, and that will resonate with them even if they're not able to show it to you in that moment.
I'm going to go backwards a little bit. So starting with peer support, um, I I'm really in this role. I've been here since April of 2022, so a little bit over 4 years now, um, because I think about my mom. I think if my mom would have known. My dad was in and out of psychiatric hospitals for most of my childhood. I grew up in Boston. Um, Go Sox. It's a hard year. Um, and I think I didn't really, we never talked about it. Dad was just going back in the hospital. Went to GW for my undergrad, and I remember I was struggling my freshman year. It was near the end of my freshman year, and I just felt like I need somebody to talk to here. So I told my mom that, and she's like, "Oh, by the way, guess you should know what your dad's three serious mental illnesses he was diagnosed with." I'm like, so much of my life makes sense right now. But when I started learning more about NAMI and support groups, not just for people like my dad, but for my mom, for family members that are dealing with this in and day out, who are trying to live their lives and raise their children, or, watching a brother or sister go through this. I think about my mom in terms of what would her life have been like. We say, and Namiism, you are not alone. And it's so true because nobody goes through exactly what you're going through, but there's people that understand because they've been there, that lived experience. And I think that's what things like support groups led by peers are just so vital because we're giving people community. And it's
Mhm.
not people who, there are people say, well, I can't go to that support group. I only have depression. well, find a depression support group. We recently started them for people living with depression and anxiety, because sometimes it's a little, maybe you don't really connect to people if they're living with, schizophrenia or bipolar. It's people, until they really understand it, tend to think it's just something I deal with. Ali, you were saying that, and I think understanding whether it's a support group like we have, or support groups like we have, or as Ali said, that person that is, that can be understanding and that can provide you that community, it's so important. But when we're talking about um, what to do next, someone asked about if someone says that they could be suicidal, that they've thought about hurting themselves. I'm going to jump just a second. We're going to talk about crisis lines in just a bit. If that is the case, call 988. 988 has been up since July 2022. And what it can be, people say, well, I'm not the one in crisis. That's okay. You can call. Because especially in our area with Marcus Alert, the person on the other side can help connect you to the appropriate people. And sometimes that's going to be, through our CSBs, and we'll talk about that, crisis, mobile crisis vans or trucks that come out. It might be serious enough that law enforcement comes with a behavioral health clinician, but let somebody that's trained be a part of that conversation with you. If they say that is a crisis. If someone says that they are considering hurting themselves, that's a crisis. That's something to deal with immediately. But understanding that, knowing we went through a whole bunch of warning signs. We talked about the time. Those really can help you think, does this person need a professional to talk to? And sometimes, especially with serious mental illnesses, getting a diagnosis, especially if we can get it early, is a huge step. What we ultimately want is for somebody to be in recovery. We want to offer hope. And that's something that you can be part of too. You can be part of that journey into recovery. But what I caution everyone, you have to take care of yourself. And if someone if someone ends their life, if that's the place that they're in, it is not your fault. Even if you've asked the question, even if you thought that they were okay because you talked to them, it's never your fault. And I want to stress that 1,000 times. Understand that you have to take care of yourself. There are times that you might have to step away, because people who are living with serious mental health concerns, not just serious mental illnesses, but I talk about my black hole, they might push you away hard. We talked about anger, but it could be so many other things. You have to take care of yourself. It's something we teach, and we have classes. They're 8-session classes, and that's one of the whole classes for family members. We call them family members, but it's people who are supporting people with a mental health concern. Um, I, I've just seen so many times that, someone in an office will end their life, and everyone around them's like, I should have known. You can't. Because why we have signs and symptoms, and we have warning signs, and all of these things, they're never the same for everybody. And people are, and I will say statistically, especially females, are really good at hiding things, because that's what we're supposed to do. We're the strong ones. When we're talking about diagnoses, if someone will, again, very gently, not pushing, if you can suggest that they speak with a professional, maybe you can help them find a resource if they don't know where to turn. Or if they just say, I tried and it didn't work, or I tried and nobody called me back. If you're in close relation, maybe you can even accompany them to a first appointment, because sometimes it's hard to say, okay, I'm here. I'm going to do this, especially if you don't want to admit anything, or if you've just been so long saying nothing's wrong. Um, Therapists, clinicians, they're trained to, they have all these signs, the Diagnostic and Statistic Manual of Mental Disorders, the DSM, much easier to say, the DSM. And it's put out by the American Psychiatric Association, and it lists all those feelings, all those behaviors, and they can put this puzzle piece together to try to move in the right spot. Being on medication is not bad. Being on medication saves people.
Mhm.
Not always not the popular opinion according to our federal administration, but it saves lives. And if a professional says that someone needs it, suggests it, it would be beneficial if that person, if they had support. These are good things. We want people to celebrate taking their medication, whether that's like an antidepressant or an antipsychotic. We want to celebrate them taking their medication every single day, like we do when somebody posts on Instagram that they went to the gym 5 days a week. It should be the same thing. We should be celebrating both. But what can you do? What can you do if somebody is going into treatment or is struggling and trying to figure out what's next? There's strategy. The buzzword now is mental wellness. Those things do help. Self-help, other support strategies that can be giving someone, empowering someone to take steps in their own wellness. We teach, I was on an industrial construction site earlier this month, and I had 200 people, 200 of these construction workers at 6 a.m. That we were teaching box breathing to. And it works because what you're doing there is you're taking control of one thing that you can control. That's your breath. Even in the most uncontrollable times, you can control your breath. So if you're starting to talk to somebody about ways to help themselves, start with breathing. It seems kind of funny, but if somebody is spinning out of control, if somebody's in crisis, giving them some control, if they realize it, is so important. But you could also check in with them, offer some help. That practical help might be, I can't go to my therapist today. I don't have a car. My car is in the shop. Well, I can drive you. Have you thought about maybe doing it virtually today? But also don't push them. Don't push them to get better. It's not, 13 treatments, 13 chemotherapy treatments, and they'll be in remission. That is not the way that mental illness works. It is this bumpy, bumpy road that somebody with a serious mental illness is going to be on that road for the rest of their lives. And so if they're struggling and you can be there for them where they're at, and that's just where they're at that moment, and not push them saying, if you went to treatment more, then you could XYZ. Then you're going backwards because you've already created that safe space, but then you're moving out of that. I saw one of the questions. What if someone won't take their medication? That is extremely normal because I will tell you, antipsychotics suck. They do. And I can say this is on the far side with schizophrenia, bipolar 1. Those antipsychotics are just terrible drugs to a lot of people. It is a lot of backwards and forwards, trial and error. I have a daughter who is, she wants to do, she's a PharmD candidate with a chemistry PhD, and she's really wants to do antipsychotic research because we know these drugs are so hard to stay on. If they don't want to take them, remind them at a good point, at a part where maybe there is some lucidity, or maybe they're listening, remind them what bad looks like. Because if someone either has anosognosia where they don't recognize that they have an illness, or they don't want to be on medication because whatever the reason, remind them what bad looks like. And that's a big thing because people don't want, a big piece of stigma, I guess, is people with serious mental illness, they become violent. No, it's not. It's that when people come off of their medications, they lose control and they don't realize it. So reminding somebody that what bad looks like and what good can look like. But you as adults, we don't have any control unless someone has legally given us some. That's hard. It is very, very hard. Know what crisis is for them, because there are people that can help you through crisis if somebody's not taking their medication.
I
Ellen?
think what I was going to add to this too, that I think is really important is not every medication is created equal, right? Like when we talk about suicide, keep in mind that there are lots of different mental health conditions. Like this is a spectrum. So when Rebecca's talking about really severe mental illness, we're often thinking of schizophrenia, we're thinking of schizoaffective disorder, we're thinking of treatment-resistant bipolar or depression. But there are also people on the other end of the spectrum who have milder symptoms, right? And even within those severe categories, there's a big spectrum. And the treatments are different for each of these conditions, and there are different alternatives within each of those groups. And so one thing that I also will remind you all is that this is really where having an expert is so valuable, because when I approach a patient, in anything, right? Mental health or other types of health, it's always a collaboration with the patient of how is it that we can best care for you? What are you open to trying in your treatment plan? And one thing that's so challenging is that we don't have control over anybody but ourselves, ever. We can make suggestions. We can be encouraging, we could be incredibly supportive, and those things go so far. And when Rebecca said, look at opportunities for what you can help do, right? The things that lower the barrier to care. So can I drive you to your appointment? Can I make your appointment? Let me help you find a psychiatrist. If a person is so depressed that they're thinking about suicide, those tasks are very exhausting and they're really burdensome. And so you doing those small things can help get them there. And it may not really be your place to convince them of a treatment, right? You can encourage and support, but also lean on the professionals that you can pull into that discussion who can help that person navigate, well, how could we do this, right? Because medication is, preferable in certain diseases and especially in more severe cases, but we also have psychotherapies, right? So medication's not the only treatment available to people. We can do talk therapy. We have what are called somatic treatments. Those are things like electroconvulsive therapy, which tends to, because of old movies and old school data, tend to scare people, but actually is a very safe and effective treatment, particularly for treatment-resistant depression. So the other thing I would say to that is remember that this is a bigger conversation. And this is a conversation that happens over time. And so your role as a peer, as a caregiver, as a family member is that when you're concerned about somebody, you're helping to connect them with an expert. You don't have to be the expert. You don't have to be in control of the treatment plan. You just have to be willing to say, I really want you to get better, and I'm here as your partner to help you do that. And
Yeah.
there are some really easy ways that you can do that. You can, like Rebecca said, call 988 if it's a crisis. If there is a suicide attempt in progress, you feel like there's something dangerous happening, you should call 911 because you're going to get more immediate emergency services, right? 988 is really um, the support network to provide more specialized mental health care and try to de-escalate a crisis. But if somebody is taking an action that could be potentially lethal or could also threaten you, you need to call 911. But the other thing I wanted to just also say is when we talk about mental health as a spectrum, that includes suicidal ideation. Lots of people think about suicide, and very few of those people will make an attempt or die by suicide. So I also want to tell you that while it is very scary to have somebody tell you that they're suicidal, it doesn't mean they're going to take their life. That is not a predestination. What it means is that we need to get a diagnosis, right? Because 90% of people who experience this have a mental health condition of some kind. And it means that we have to treat that mental health condition to get them better. But it
I,
doesn't mean that they're definitely going to make an attempt or die by suicide. And so I think this comes with practice, but being able to hear those words and not panic, but have a really good, calm, planned response in the moment is also really valuable. I had a friend call me once and she said, Allie, I really need to talk to you. I've been incredibly depressed and I've had some thoughts about suicide and I didn't want to tell anybody else because I thought they would freak out. So, I guess my take home message, hopefully that you learn from me, is that this is all a spectrum, and that being present, opening the door to these conversations is hugely important because silence is never the right answer. AFSP has an entire campaign called "Talk Away the Dark" because talking about mental health right now, it's coming out of the shadows, and we need to keep pulling it out of the shadows. We need to make it more normal to have these conversations and make it less scary, so that we can teach people what to do about it and to normalize that going to the doctor for this is okay. And if you don't want to go see a therapist or you can't get in to see one or you can't get in to see a psychiatrist, you can go to your primary care, go to the emergency room, go to an urgent care. All of these people are prepared to help you.
I think, you mentioned about ideation. I remember one of my children cutting. And I thought for sure, because I had never, it wasn't in my vocabulary. It wasn't something that I had been privy to. I didn't understand it. Um, but things like that, immediately I thought they're planning on ending their life. Like this is what this is what that it is. And I did panic. I didn't know what to do next. I learned it's taking away some other pain. It's a mask almost. We talk, it can be. I'm generalizing again. We think about, I talked about chicken or the egg with substance use disorder. Um, and what someone explained to me with things like self-harm is it could be masking in terms of if I cause this pain, then another piece of my life, what I feel pain um, will be less. It could be call for help as well. Notice me. Notice that I'm struggling. Understand that. And that all made sense to me, but I hadn't heard. It wasn't something I knew. In my own journey, I hadn't seen that. And maybe maybe it's a Boston thing where we just didn't talk about it. Pretty common, but I know that I didn't hold it together. I definitely was not Ally Walker in that situation. It was crying in my shower with my clothes on type panic because these are my kids. Um, I've learned a lot since then, but we have to remember that that there's so many nuances to this. And, going way back at the top of our conversation here, just we can't understand what someone's going through unless we ask them. And so it, if you have girls in your family, you know that some will tell you anything too much. I'm sure one of my kids is laughing at me right now hearing that. But they might not tell you this. So that's where treatment comes in. That's where a supportive person, it doesn't have to be a clinician. It doesn't have to be a therapist. We have so many people that don't want to be in therapy for different reasons, whether they can't afford it. It's very prohibitive in some situations. It's also looking for cultural appropriateness, people who they can actually be on a good level with, whether that's because of their race, maybe sexual orientation, but finding people that your person, child or adult, can actually feel comfortable with. It might not be talk therapy. It might be equine therapy or art therapy. There are so many modalities that can help people. And sometimes, just like with medication, it's trial and error. It's understanding, no, therapy didn't fail you. You just have to figure out what works for you. Um, and it can be a process. Some people won't talk to someone of the opposite gender. Some people, that's what they receive, that's what they want, is they want somebody else. They want a different opinion. Um, so that be patient. Be patient with yourself. Be patient with the person that you're concerned about. Because it's not linear. It's not a straight line. No piece of it is. Allie talked about how in the clinical setting, you want the person to be part of that conversation. And in serious mental illnesses, that's something you have to teach because oftentimes that is taken away from people when they're in crisis. When they're in crisis, they not have the ability to be part of their treatment. At NAMI, we teach what I call big A and little a advocacy. So little a advocacy in terms of this is teaching how to be a part of your own treatment, how to be a part of your medication, how to be a part of your recovery, but also on the family member side, how to advocate for someone. Somebody mentioned if they won't take their medication, how can you be part of that advocacy? Um, we do big A advocacy too, which is policy advocacy. Very different things, but that's a piece of this is, as you are little a advocating for someone, making sure that they understand they are not failing. The drugs don't work for them, or the therapist or the modality of therapy doesn't work for them. They're not failing. They're working at it because recovery is hard work. Getting there is harder. Um, so we can get to some questions. We wanted to talk about some resources because we're talking a lot about what to do, where to go. I'm just going to share my screen. I promise we didn't want a lot of a lot of slides here. So bear with me on these. But Allie, you want to talk? Should we do CSB first and then talk about helplines and 988 and stuff? Does that work?
Sure. Yes.
So hopefully you're all familiar with community service boards. Or you'll hear CSB a lot. I'll tell you when my family was in crisis and we needed it, I had no idea what the CSB was. And I live near about 2 miles away from the Bulliva Center in Fairfax County. Didn't have any idea. But in Virginia, we have 40 CSBs around the state. We're a part of Region 2, and there are 5 CSBs in our area. So CSBs are a public agency that provides services for people who have mental illness, substance use disorders, and developmental disabilities. They also have wellness and prevention initiatives like ACE, interface trainings, mental health first aid, Revive, which is Narcan training, and a bunch of suicide preventions. but they also can help connect you to resources such as, drug disposal bags, locking medication boxes. They are the resource and we're so lucky. I'm on our national board of directors, and I get to see other communities across the country, and to have this one thing, this one entity that is the provider for government services, for public services, is incredible. And they're great partners, I know, with us, with AFSP, with SPAN. So understand your CSBs. Loudon has a different name. They're still a CSB, but this is just some of the information. This is where you can go to find out, or who to call. This is to see if maybe your person, thank you, Caitlin, if your person can be part of the CSB, if they can help you. I think that is something that, we should all be very proud of in terms of that. But what if it's more immediate service that you need? You want to talk 988?
Yes, I would love to talk 988. So, for anyone who's not familiar, I know we've kind of mentioned 988 a couple different times. This used to be a really long number. It was 1-800-273-8255, which most people outside of this niche space probably can't memorize. And so there was a huge amount of activism around trying to make it easier for people experiencing a mental health crisis, right? And we're talking about suicide, but this lifeline can also be utilized if you're having a mental or other kinds of mental health crises, including substance use. There was a huge movement to try to make it more accessible. And so we followed the same kind of model as 911 in creating a 3-digit number called 988, which gets you to a trained person on the other end of the line who is specifically able to help de-escalate in a crisis around suicide, that's able to help you navigate resources in your community. And then the other thing that's really important is some people worry that they will dispatch emergency services to your home. 988 is different from 911 in that it does not track your address. It doesn't know your location. And so when you contact this number, you have to give that information to receive those emergency services if they are indicated, right? So I think that's really important, and it was built with intention because we know that sometimes people are very fearful that police are going to come knocking on their door, and we don't want that to divert people away from seeking help when they need it. 988 is incredible because it is available 24/7, 365. It is completely free. It is available in numerous languages, including Spanish. They have a special line for veterans. You can chat online. You can text the line. People in the millennial and under generations are big texters, so that's really popular. But really, this is an incredible resource. One thing that's so easy to do to help somebody you're worried about, and also for yourself, is to save this phone number in your phone. And I encourage you, call it, even if it's not an imminent crisis where you think that person is really about to take their life, but you are just feeling really stressed and uncertain of what to do. This resource is also for you. They can also help you work through that. So I have a friend who struggles with depression, and sometimes a lot of people have escalation of symptoms at night when they're alone. And it can be challenging as a support person to be available at those hours. You have to, again, as Rebecca said, take care of yourself. And this is a way that somebody else can step in and be there. And so I have a friend who, when he is really depressed in the middle of the night, he calls this number, and sometimes they just stay on the phone until he falls asleep. So they're really incredible. The Trevor Project is another nonprofit organization that supports LGBTQ youth in particular. And they have their own crisis support services that are listed here as well. Really wonderful. If you ever go to their website, it's super cool because it has a very easy way to hide the window immediately. So for somebody who maybe isn't out yet or in an environment where they feel unsafe being out, they can close it off quickly. But these services are specifically designed to support those folks. Do you want to talk a little bit about the NAMI helpline?
Yeah, so just real quick on also going to what Ali was saying about the anonymity. So there used to be a problem. So 911 is what's called geolocation. So it goes specifically to, you can track where it's coming from. You can track where that call is coming from, which is super helpful if you're thinking about, emergency services needing to get to somebody very quickly. When 988 first started for the first couple of years, I have, if being from Boston, used to have a 617 number. If I would call on my mobile phone 988, I would be routed to the lovely people up in Massachusetts because it was routed from my phone. Now, when you're looking for resources, either for yourself or for somebody else, getting as close to where you are as possible is much better. So last year, 2 years ago, implemented in 2025, is geo routing. So now you're routed to your location. Our regional call center here in Northern Virginia is manned and just amazingly worked on by an organization called HopeLink. If I was to call now, even with a 617 number, and I was sitting in my house here, I would be I would be routed to my area call center. So the people offering you resources on the other side are people in your community or close by. Um, so that's something to remember, but that's all it does. It just puts you in the right location so that you're moved over to not by your phone number, but where you are. Keeping that anonymity and keeping that ability that you don't have to give specific information, or you don't not going to all of a sudden have somebody knocking at your door unless you do provide that information. Moving to kind of the non-urgent stuff. Some are called warm lines, some are called resource lines. NAMI has a national one, and we also have here in Northern Virginia, we have a helpline as well. These are resource based. So the people on the other end understand what the processes are around us. They understand how to navigate systems, and they can help with what your next step should be. They're also going to tell you, though, like one of the hardest conversations I think our helpline people have to have sometimes is you're a parent of a adult child. You're wondering, how do I find out where my son or daughter is because they were moved to jail, a state hospital somewhere, and you might not have the right to that information. That's a super hard conversation to have. And understanding, I'm going to go back to when things are good. If you are in relation with someone, if your support system, like direct support system of someone who lives with a serious mental illness, someone who might, you worry about being in crisis, get that paperwork signed early so that you can have access, you can have a legal power of attorney, you can have legal health care, you can move through HIPAA. There's a whole bunch of different things that can be helpful in situations like these. Those are the kind of things that our helplines can help. I put the PSVA number here. We see this a lot. We see postpartum women, but also women with pregnancy loss have incredible mental health needs. And we're very fortunate to have PSVA in terms of postpartum support. There are so many other helplines. And if you're looking for something specific in terms of resources, I encourage you to call one of the resource lines here or Google about Virginia specific. And there are so many. And that's good. This is not a bad thing. It's not a competition thing. The more people that we can touch as a community, the better. So what questions? We can take them. I'm going to stop sharing. Oops, I guess I should have gone back to that. Caitlin.
Yes, we had a question in the chat that says housing for people with serious mental health is a huge issue. Any suggestions? Family member has already done inpatient and IOP, and PHP needs to have supportive housing program and can't find any for them.
So there are programs. Cornerstone, one of the great ones. There are, the issue is having enough, and there's not enough. Um, and so I would encourage, you're welcome to call our helpline and get a complete list of the wonderful agencies that are helping people with serious mental illness, especially those living at SSDI. Um, I encourage you to, we have great ones in our area, but like everything else, affordable housing in our area doesn't always mean affordable for everyone. Oftentimes we hear affordable housing, and what a lot of people in government and the policymakers consider affordable is actually workplace housing. When we're talking about someone living at SSDI, which so many people are with a serious mental illness, there's very particular places that will not only help them live independently, but provide them with the wraparound services that they desperately need to stay in recovery. So I encourage, they are there. It's really a matter of space and location. Are there any other questions that we can answer? Thank you for putting that up, Caitlin.
And thank you for all the questions so far. I think these have been really thoughtful questions and questions that I think are very relatable to a lot of people as well.
I am going to put up one more slide, I promise. And this is contact information for us as 3 groups. And we can send this out afterward, this deck, but SPAN, I encourage you to go to our website, take a look at all of the wonderful resources that we have there. AFSP for National Capital Area, which Allie is part of. And then there's our information for NAMI Northern Virginia. So I encourage you to take a look around on our sites and our resources, but also contact us. We're all here to help, and I hope maybe you won't need us, and you won't need 988, but we are here to help. So, Allie, any last thoughts?
I just put in the chat the web link to our chapter page. You can also get to it with a shorthand, so I just added that as well. National Capital Area Chapter, we just abbreviated as NCAC. But no, I think you covered everything, and I just really appreciate the opportunity for us to have this conversation. I feel like, like I said, that some really thoughtful questions were asked this evening, and I really hope that this information is helpful. I know that this is a scary topic, an intimidating topic, and I think that people have moved into a broad state of readiness to reach out and ask people how they're doing and open these conversations about mental health. And we're now training you all to know what you do with that information. And so I appreciate the opportunity to have this conversation. And please take advantage of the resources that we've shared, because this is the beginning of much more learning for all of us. It's always a continuous learning journey. So take advantage of these resources. Everything that AFSP provides is completely free. We have lots of different kinds of education programs, whether you're interested in learning more about suicide prevention for young people, for older adults, for people in high risk occupations, just general information like what we talked about tonight. We can bring those presentations to your workplace, to your PTA meeting, wherever. So, please just know, like Rebecca, myself, Alan, all the people from these community services boards and so forth, we're all working together in collaboration to try to improve access to care in our community and to improve awareness of what people can do and empowering them to take action. So I really appreciate everybody's time tonight.
Alan, last words. It's all you.
Well, thank you. There was a lot of information tonight, and I really appreciate it. I will let you know that this was recorded, so it will be on the Suicide Prevention Alliance of Northern Virginia website in a few days, so you can go back. Hopefully you will also share it with your colleagues and friends and family members. I do want to give a shout out that for the Suicide Prevention Alliance of Northern Virginia on our website, we have a mental health screening tool that's new. That's we just started back in April. It's a free anonymous self-assessment tool that you can answer a few questions. It'll give you some results and also link you to resources. Again, another source of resources. Allie and Rebecca talked about a lot of trainings. You can go through our community services board. Oftentimes, those trainings will be listed on the SPAN website. In addition, it was mentioned earlier about locked medicine boxes. All of our partners give those out at community events. We also have gun and trigger locks that are provided free. The lock boxes are provided free. Some places actually you can go to the clerk of the court and pick up these items as well. We are very fortunate to have the American Foundation for Suicide Prevention, NCAC, as a member of SPAN Leadership Council, NAMI Northern Virginia as the Leadership Council, all representatives of all 5 community services boards, as well as some other organizations. In addition to that, I just want to thank Allie and Rebecca. One of the things that came up tonight, Allie and Rebecca talked about their own personal lives and things that have happened. One of the things that's really important for reducing stigma is talking about what happens. It's amazing that I think if you really start talking to people, you will find more people have had a friend, a family member, a colleague struggle with mental health, and none of us are alone. It has touched all of us in one way or another. And the more we talk about it, I think the more that people will actually reach out for services. All of you are all part of the prevention initiative. And whether it's through NAMI, AFSP, those community services boards, SPAN or whatever, please get involved whichever way, whether it's helping an individual, whether it's advocacy in a local community, or whether it's just helping us as we do some of our tabling at certain events. I want to thank all of you for being here tonight. And I particularly want to thank Allie and Rebecca for all the information that you shared. And I want to thank all the other members of the Leadership Council for everything they do every day, too. So with that, I hope you all have a happy and healthy rest of the May, and throughout the rest of the year. And thank you so much. Good night.
Thank you. Good night, everybody.
Good night, everyone. Thank you.